Okay. The heart chapter, chapter 17. Okay? The ancient Greeks thought the heart was the seat of intelligence, right? And such. The heart is basically two pumps, okay? Two pumps. And one side of the pump pumps blood to the lungs to get oxygen, and then back to the heart. The other side pumps the blood to my toes, to my fingers, to my brain, okay? So it's basically two pumps. The heart is basically two-sided. Has a, what's this right down the middle of your nose called? The septum, right? Has a septum right down the middle of the heart. Yes? Okay? So, the right side is the pulmonary circuit, P-U-L-M-O-N-A-R-Y. The pulmonary circuit, right? Pulmo, right? Lungs, air, okay? The left side of the heart is systemic, S-Y-S-T-E-M-I-C, systemic. Okay? Systemic meaning it pumps blood everywhere, all the way around, all the way to the tips of my toes. Sorry. Okay? Now, let's talk about the heart, the pulmonary circuit, the right side, okay? Now, of course, the top of the heart, right? You got your septum down the middle, yes? You got your right side, you got your left side, yes? Okay? Now, the right side is pulmonary, P-U-L-M-O-N-A-R-Y. Left side is systemic. Okay? This side of the heart pumps it to the lungs and back. This side of the heart pumps it to the toes and back. Okay? All the way around. It's systemic. Okay? So, excuse me. Whenever we draw the heart, we always draw it like this. Yes? You probably already know. These are the atria, right? And these are the ventricles on the bottom, right? You already know that. But here's the thing. In the body, the heart is really actually twisted. And the right-hand side of the heart is up front. And the left-hand side of the heart, the systemic, is at the back. Instead of like this, it's twisted around like this, basically. Okay? So, when we did the pigs, when we did the plucks, then you'll be able to see that. Okay? So, okay. The atria, let's talk about that. Yes? In front of the building, you come in the front of the building, there's a glass room, right? What's that called? Atrium, right? Atrium, right? The entryway, yes? In the same way, blood coming back to the heart goes into the atria. The atrium, okay? The atria, okay? Right? Those are the receiving chambers. Atrium singular, atria plural, okay? Right? Down here, the ventricles. The ventricles are really the pumps, okay? The atria receives blood, but they're thin-walled and they're not very powerful. Where do you get the power from? Down here, and actually the left one. Okay? In order to pump blood to my big toe, I got to have a big, powerful pump. Okay? Let's talk about that for a minute. from my heart to my lungs is this far, right? So the right side, the pulmonary circuit, only has to pump blood about that far to my lungs, yes, and then that far back, right? Okay. However, the left side of my heart, the systemic, it's got to pump blood from here to my big toe and back, right? And so because the longer the blood vessel, there's going to be more resistance. Okay? Now let me grab this right here. If you look at this right here, right? Would it take more pressure to pump blood from here to here or from here to here? See, as a fluid goes through a pipe or a blood vessel, right? It rubs up against the edge, and that causes resistance, peripheral resistance, right? So because this is so much longer than this, it takes more pressure to pump blood a long way. If you try to pump water a short distance, it's not a problem. But if you try to pump water miles, it takes a lot of pressure to do that. Okay? Right? Because the longer the pipe, the more resistance. Yes? Because the fluid rubs against the sides and causes friction. Okay? Now, the heart, the mass of the heart is about 250 to 350 grams. I knew that was wrong. Right? Right? Oh, by the way, a pound is about 360 grams, right? So a pound's 360. So the heart's 250 to 350. What I'm getting at is a little less than a pound is the heart, okay? Now, I need to tell you this too. In the thoracic cavity, we got our lungs, we got our heart, and this area right down the middle where the heart sits is called the mediastinum. Stein means chest, okay? Mediastinum. Mediastinum. Okay? That's where the trachea comes down and splits into left and right. We got a lot of lymphatics in there. We got a lot of blood vessels in there. In fact, there's some surgeons, that's their deal. They work on this much, the mediastinum, okay? Right down the middle, thoracic surgeons, okay? But anyway, you need to know that word, mediastinum, right? The middle of the chest, okay? All right? Now, the heart sits on the diaphragm, and in front of the heart, you got the sternum, and behind the heart, you got this anterior part of the vertebrae, the spine, right? That's where it sits, okay? Now, around the heart, you got the pericardium, okay? Right, way back to chapter 1, yes? You got the visceral and the parietal pericardium, okay? The two pericardiums, right? And in between you have fluid, right? The inner layer, the endocardium, okay? Or epicardium, pardon me, epi meaning upon, touching the heart, yes? Okay? The outer layer is called the fibrous pericardium. And the fibrous pericardium ties the heart down to other structures so it stays in place. Okay? It protects the heart, it anchors it. I said tie it down, the book says anchors. Okay? And the pericardium keeps the heart from filling up too much. If the heart filled up more and more and more and more, it would get overstretched. Okay? The inner layer is the serous pericardium. Serous meaning it secretes a serous fluid. Serous fluid is water with some protein. It's slick, right? And so think about when you're running a race and your heart's going boom, 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 boom. If you didn't have that serous layer, you would get a lot of friction, right? Yes? decreases friction, right? But anyway, this fluid decreases friction, okay? Again, the innermost layer, the epicardium, epi meaning upon the heart. In here is the pericardial cavity, P-E-R-I-C-A-R-D-I-A-L. The pericardial cavity. Had the same thing in the lungs. I think that's next chapter, but anyway, okay? Right? Pericarditis, what would that be? Pericarditis, what does itis mean? Always.
Inflammation.
Inflammation of the pericardium, pericarditis, okay? Right? When you get pericarditis, when they auscultate your heart, way back to chapter 1, auscultation, A-U-S-C-U-L-T-A-T-I-O-N, auscultation. That means with your stethoscope listening to the heart, okay? When you hear that, you'll hear, it's called a friction rub, okay? If you get pericarditis, okay? If this becomes inflamed, right? Can lead to adhesions in the visceral and parietal. These two will stick together, right? Basically, you get pus in here. Can happen, okay? Now, if it's very severe, then you will get blood in here, you will get pus in here. Basically, maybe before the days of the airbags, nowadays the airbag goes off and you hit the airbag and you don't hit the column on your chest, right? But in the olden days, when I was a kid, you went bam into that horn button, right? Yes? Okay, so a severe blow to the chest can cause that. And what happens is, you can't breathe and your chest hurts very deeply. And you have that friction rub, right? And what they have to do for that, it's an emergency, is right? You stick a needle in there and you suck some of that fluid out, right? And you suck it out, right? And that is called a heart block, or the medical term for it is cardiac. It's called a heart plug, okay? Heart plug, right? But the technical name for it is cardiac, T-A-M-P-O-N-A-D-E, cardiac tamponade, right? Yes? I don't think I need to tell you ladies what a tampon is, right? Okay? Cardiac tamponade, when that swells up and such. You get pericardial effusion, and again, they have to drain it. Sometimes they have to do that a couple of times. In extremely rare cases where it's viral or bacterial, they literally cut this away from the heart, okay, to take care of that, okay? Now, let's talk about one of my friends literally driving this old beat up pickup truck, boom, hit it and had this from hitting his chest on the right. He was one of these guys that could drive any kind of car he wanted to, the fanciest, nicest, brand newest pickup truck, and he drove a 30-year-old pickup truck, right? Yes. Probably could drive that pickup truck because he saved his money over the years and didn't waste it on fancy cars. But anyway, that's another story. Okay? Let's talk about the 3 layers of the heart, right? Okay? Make sure you get that though. Cardiac tamponade is what that is. Okay? The friction rub. Okay? Make sure you get that. Right? Okay. The epicardium. Right? Okay? The visceral layer of the serous pericardium. Then the myocardium. Myo means what? Okay? Myo means muscle. Myo means muscle, right? Myocardium. That's when we think about the heart muscle, right? Okay? The cardiac muscle, the bulk of the heart, the contraction part of the heart. Okay? Muscle bundles linked by connective tissue. Okay? There's also that myocardium, there's actually connective tissue, they call it a cardiac skeleton. It's not bone, but it gives the heart its shape and supports the heart, okay? And then the endocardium, E-N-D-O-C-A-R-D-I-U-M, the endocardium, right? The endocardium lines the inner chambers of the heart, okay? It is squamous epithelium, okay? S-Q-E-P-I-T-H-E-L-I-U-M, right? Epithelium, where the outside world meets the inside world. It's shiny, it's glistening, it's white, it's very slick. We call it endocardium in the heart, but it is contiguous with the blood vessels. The same stuff. In the blood vessels, we say endothelium. In the heart, we say endocardium. It's the same stuff, okay? It's contiguous, just one flowing thing, right? Because as blood goes through the heart, we want it to come into the heart and get squeezed out of the heart and not get slammed around, right? Because if it gets slammed around or if it's rough, the blood vessel, the red blood cells will break, okay? The very first artificial heart, right? He was a dentist. Harvey, what was his last name? Harvey something. And he lived about 3 weeks with an artificial heart that pumped his blood. And one of the problems with the heart was, yes, it was efficient and it pumped the blood, but the blood slammed into the chambers of it and broke the red blood cells apart, okay? And so too much pressure. So anyway, endothelium, lining the heart, right? Okay? Okay. Again, the atria, the ventricles, interatrial septum, interventricular septum, okay? Right? And again, the right side is actually the front of the heart, if we're looking at it. And the left side, the left side, the pulmonary, it's got to be so much bigger, stronger, more powerful to pump blood to our big toes. And so the main pump is the left side of the heart, okay? And it's so much bigger, yes? Now, how many of you ever heard, oh, my friend, they had a baby, it has a hole in its heart. It may have to have surgery. Have you heard that one? Okay. Well, what happens is right here, when you're in your mama's tummy, you got a hole in between the two because blood flows in here and then it'll go across to there, right? Because mom's heart's doing the work of oxygenating the blood. But anyway, and that is called foramen. Foramen means hole. Foramen ovale. O-V-A-L-E. Let me make sure. Yep, I spelled it right. Right? Foramen ovale. And what happens is right before you're born, or right after you're born, this hole closes. Yes? Right? Okay? That's normal. In some kids, it never closes. Right? When it closes, it leaves, if this is the septum, it leaves a little divot, right? A little divot, right? And that's called fossa ovalis, right? Foramen meaning hole, fossa meaning a scooped out spot, okay? Right? That's the difference. Foramen ovale and the fossa ovalis, okay? The fossa ovalis is a dip or a depression, and this is a hole, H-O-L-E, right? A hole between the two chambers, yes? And again, before the baby goes home from the hospital, they're checking the baby, make sure it's healthy, and one of the big deals is they listen to the heart to make sure, and listen for, it'll have a murmur or a swishing sound if this doesn't close. Some people go through their whole life and it never closes. And some people believe that, I had a friend that his daughter was at college age and they found that hers had never closed and she had migraine headaches and so they stuck a wire and they burned it to close it and that was supposed to help her headaches and it didn't. But anyway, that's one belief, right? Yes? Okay. David Goggins. David Goggins. I don't know if you know who he is. Pretty famous Navy SEAL guy. He had this and had it fixed, and he didn't find out until he was already a Navy SEAL and all that stuff. Anyway, years later. Okay. The atria. The atria are thin walled. Okay. Right. As the blood comes into the atria, gravity, if we're upright, is going to send it down here. The atria are not really the pumping chambers. They're just the receiving chambers. The ventricles are much more the pumping chambers, the stronger part, okay? The atria don't contribute very much to the propulsion of the blood out. It's those ventricles, that's their job, okay? Now, okay, make sure you get these foramen ovale, fossa ovalis. The whole, foramen means hole, right? Right? The hole in the bottom of the skull, the foramen magnum, right? Foramen means hole. Fossa means a scooped out spot. Usually, when you're talking about bones, it's the scooped out spot. But anyway, okay? Make sure you get those, right? Now, you're going to have to learn the blood vessels to the heart, okay? Right? Great. So close. You know, Michael Jordan, 13 times they threw the ball to him, and he threw it up for a buzzer beater, and he missed 13 times. 13 times. But a gazillion times he made it and won the game. Right? But I've always remembered that. Michael Jordan, he said, well, I failed over and over and over again. Right? 13 times. I'm going to win the game. Throws the ball up and he missed it. Yes? He wasn't a quitter, though, Michael Jordan, was he? You know? Superior. Vena. Cava. Inferior. Vena cava. Right? Superior and inferior vena cava. Right? Veins. Where do veins bring blood? Towards the heart, right? Right? So you got your blood coming in, you got your blood coming here, right? So guess what above the diaphragm? Superior vena cava. Below the diaphragm? Inferior vena cava, right? Yes? Oh, by the way, there's one more thing right here. There's another opening, and that is, I'm just going to write it over here. That is the opening of the coronary sinus. Okay, let me see if they show it here. Okay, here we go. Okay. Yikes. Okay. Now, when we think of sinuses, we think of, oh, okay, frontal, maxillary, ethmoid up in there, right? We think of those sinuses. But a blood vessel, a vein that is dilated and flat is called a sinus, okay? So on the very back of your heart right here, the veins come together, right? And that is the coronary sinus, and it dumps into the right atria, okay? So the coronary sinus, right? So that right atria is going to have three things that dump into it. One, superior vena cava. Two, inferior vena cava. Three, coronary sinus, okay? Right? That's what comes in. Okay, on the left side of the heart. Okay, on the left side of the heart over here. Yes? If you look on the back of this heart here, you got two red ones sticking out over here, and you got two red ones sticking out over here, right? There's four of them. Two from the left lung, two from the right lung, right? And the blood is coming back and the blood is coming back from the heart, right? And these four, 1, 2, 3, 4, those are the pulmonary, right, from the lungs, veins, the pulmonary veins. Okay? Now, why did I draw it in red?
Because they're oxygenated?
Because they're oxygenated. Yes, sir. They're oxygenated. That blood is coming from the lungs, right? And it picked up oxygen in the lungs. But listen to me. They're veins. Normally we think veins blue, right? Veins are bringing blood back to the heart. Well, these are bringing blood back to the heart, but it's oxygenated. Okay? One of the few instances where veins are carrying oxygenated blood. Okay? The other is in the baby before we're born, but I'm not going to talk about that. Okay? Pulmonary veins. Even though they're veins, they're carrying red blood, oxygenated, right? Remember, oxyhemoglobin, deoxyhemoglobin, right? Oxyhemoglobin. Okay? Yes. Okay, let's talk about the bottom of the heart, the ventricles, okay? The ventricles, yes? Okay? The ventricles, again, are the pumping chambers or the discharge chambers. And most of the volume of the heart is the ventricles. They're way bigger than the atria, okay? All right? Now, let me get my little deal here. For me just a minute. Okay. If you look on the inner part here, can you see how it's really rough? And there are ridges, right? There are ridges, and it's very rough, right? And that's muscular, okay? Now, that is called trabeculae carne. Oh, by the way, anybody speak Spanish? What does carne mean? Like meat, muscles, flesh, right? Okay, that's where it comes from, the root, okay? Now, when I was in school, it was called columnae, C-O-L-U-M-N-A-E. So you might possibly see that in certain books. Columnae for columns, columns of flesh, okay? The inner part, you will see when we do the inner part of that heart, it has these ridges in it, okay? And that's muscles. And remember, endocardium covering it, so it's very smooth, okay? But make sure you get that. Columnae carne or trabeculae carne, okay? Right? The inner surface of those ventricles, okay? All right, you're going to have a valve here and a valve here. Let's talk about those first. And the valves of the heart have cusps on them, okay? On this side, if I took the heart valve and I turned it this way so you could see it from the top, it would look like this. If I did this one over here, it would look like this. 1, 2, 3 cusps, they're called, okay? 3 cusps, right? So therefore that is called the tricuspid, okay? That's on the right-hand side. On the left-hand side, over here, guess what? There's only 1, 2, right? So that is the bicuspid, Bicuspid. Oh, by the way, most of the time we don't say bicuspid. Most of the time we say mitral, the mitral valve. That's its name, M-I-T-R-A-L. Why is that a big deal? Because about many people, their mitral valve is incompetent, it doesn't close all the way. And about, they say like up to 25% of ladies, the mitral valve doesn't close all the way. Okay? And certain people, it's so bad they have to have that mitral valve replaced. Okay? Most people, they go through life, it's not a big deal. But anyway, but especially common in the ladies. Again, this side. Okay? And this is the atrioventricular valve. Right? The AV valve is atrioventricular valve, AV valve, right? That's the tricuspid, and this is the bicuspid, the mitral. Okay? Okay. Now, on these valves, on these cusps, right? When the heart squeezes, that causes pressure. And things are going to go from high pressure to low pressure, right? They're going to go from high pressure to low pressure. And when the heart squeezes, pressure is put on these valves, okay? And to back these valves up, you have little muscles, and those are called papillary, P-A-P-I-L-L-A-R-Y. Papillary muscles, okay? And those are attached to tendons. Those tendons are called C-H-O-R-D-I-N-A-E, coordinate tendonae, T-E-N-D-O-N-A-E, coordinate tendonae, and they're attached to that valve. And if you look right there, can you see the tendons? Okay. Can you see the tendons there, the tiny little strings? Yes. Okay, let's go back here. Can you see the little tendons? You will see them when we cut open the heart. See the little stringy tendons there, right? And on the end of those tendons, we have muscles. See the little stringy tendons there, right? Okay. Right? Can you see the little tendons there, right? Okay. And those tendons are attached to the valves, and they are they're called coordinate tendonae. Think about a cord is another word for like a string, or a rope has 3 cords tied together, right? That's the coordinate tendonae, and these are the papillary muscles, right? And what do they do? Okay, well, think about this. If you have a highline pole, many times you have a wire right here, right? That goes into the ground. It's a guy wire, right? It helps hold the pole up. It's a guy wire, yes? That's what these are. It keeps the valve, when the pressure gets put on, it keeps the valve from everting, opening up, right? Because the tendons, when it goes like this, pulls the tendon tight, papillary muscles clamp down, right? And it keeps them from opening and everting. It's very important for blood to get squeezed from the top to the bottom, from the bottom out of the heart, okay? You do not want backflow. Backflow is bad, right? That makes the heart an inefficient pump. And we'll talk about that. It's very common, backflow, by the way. But anyway, okay? So, okay. The right ventricle, okay? The right ventricle here. We said into the atria, the superior and inferior vena cava, the coronary sinus, and blood is going to get pumped out here. Right? Right? To the lungs. This is the pulmonary trunk. P-U-L-M-O-N-A-R-Y. Trunk. Right? Yes? On highways, you have a bunch of highways together and it's called a trunk, and then a bunch of feeders split off. But anyway, okay? The pulmonary trunk. And it's going to go, notice, The right side of the heart, the blood is blue because it's deoxygenated. Yes, the pulmonary trunk I draw in blue because it's deoxygenated blood, right? Once it goes to the lungs and back, it's going to come here. Okay? Now, okay. Now, right here, okay, you're going to have a valve right here that prevents backflow. That's going to be, there's going to be one on this side too in that aorta, and those are called semilunar valves, okay? Semilunar valves, S-E-M-I, semi means like half or partial, semilunar. Right? Why are they called semi? Why in the heck? What does luna mean? What does lunar mean? What? Yes, ma'am. Yes, okay. Right? So this valve looks like this. Okay, and this side of it looks like a crescent moon, and this side looks like a crescent moon, right? And it's going to close like that. So they're called semi. They're not a full moon, they're semi-lunar valves, okay? But usually what happens is, instead of calling them semilunar, they will call it the pulmonary, and the other one on the other side they're going to call aortic. But anyway, technically their names are semilunar valves, okay? Right? So, through the semilunar valve, right? Remember tricuspid and pulmonary valve, pulmonary semilunar valve, technically, okay? To the lungs, right? Goes to the lungs, gets oxygenated, comes back right here through the pulmonary veins. Remember we said 1, 2, 3, 4. To see the pulmonary veins, because the heart's twisted with the left side of the heart on the back, you have to look at the back of the heart to see these. That's why this is the front of the heart here. So if we turn the heart around, look at the back, there's 2 over here, 2 over here. Okay? Boom, coming into the back of the heart, right? And that's what comes in over there. Okay? Now, we're going to go, blood's going to come in here from the pulmonary veins. It's going to go through the bicuspid, but more commonly called the bicuspid, the mitral valve. Yes? And then what happens is, this left side is really the powerful pump. And it's going to pump blood right through the aorta. Yes? A-O-R-T-A, the aorta. And this is the aortic valve, or the aortic semilunar valve. Okay? You're going to have to know the valves. You're going to have to know what blood comes in, as in superior and inferior vena cava, coronary sinus, pulmonary veins, and what goes out. The pulmonary trunk, pulmonary going to the lungs, and the aorta, right? The aorta, this part is the ascending, it's going up. This is the transverse, and this is the descending aorta. Oh, by the way, where does the aorta end up going? Comes up, makes a big loop, and it comes down, right, on the side of the spine, and it splits into left and right iliac, right? So I get blood flow to my toes. Yes? Okay? Now, branches of the aorta, 3 major ones, right? Right? Going to my brain and all that other good stuff. Yes? But anyway, okay, let's see where I'm at here. Okay, again, the purpose of the valves, we don't want backflow. Okay? Okay? Now, notice, superior and inferior vena cava, right here where they dump into it, right? There's no valves, so you do get a little backflow. Here, these pulmonary veins, no valves either, so you do get a little backflow there too, okay? Because there's no valves. right? But the main thing is tricuspid on the left side, the mitral on the right side, and another name for the mitral is bicuspid. Now, let me ask you this. This has 3 cusps. 1, 2, 3. This has 2 cusps. How come? And I'm going to tell you right now, I don't know the answer, but I have a theory. How come? Why would that be? Why would you have 3 cusps on the one side and 2 cusps on the other side? Tell me. Let me know. Inform me. School me, please. Why would that be? Well, the only thing I can think of, because in nature, there's a reason for almost everything, okay? This stuff about nature being random, I don't believe that. No, it's too perfect. It's too amazing. Here's what I think. This is my theory. The left side of the heart has to pump the blood this far. The right side of the blood has to pump the blood from my big toe, from here to my big toe. That's over 4 feet, right? So this is the high pressure side of the heart. This is the low pressure side of the heart, okay? Because this is the high pressure side of the heart, the left side of the heart is the big, powerful squeeze and pump side. My theory is, because this is high pressure, if you just have one seam, you're less likely to get valves that are incompetent, that are loose, that backflow. And over here, there's not near so much pressure, so there's 3 seams. That's just my theory. I don't know. I wish I knew. If you know, please tell me, okay? But that's my theory, because this is the high pressure side and such, right? Okay. Okay, and again, the pulmonary and the aortic semilunar valves, right? Aortic and pulmonary. And I gotta get going, I'm going slow, okay? We talked about arteries away from the heart, veins towards the heart, okay? We talked about the pressure differences, right? Now, if you take the blood pressure in this pulmonary side of the heart, right, versus the real pumping side of the heart, right? What's the normal blood pressure?
120 over 80.
120 over 80, right? 120 over 80, that's a great blood pressure. That's what we're thinking. Guess what a normal blood pressure on this side of the heart is, in the pulmonary system? Remember, this is the low pressure side of the heart, right? 24 over 10, about 1/5, okay? 24 over 10, right? It's not important for me that you exactly know that number. Of course, you want to know 120 over 80, but the thing is, realize this right side of the heart only has to pump this far. The left side of the heart, a long ways if you're as tall as I am, right? So it takes more pressure. Yes? If you pump water 100 yards, it doesn't take very much pressure. If you pump water a mile, it takes a lot of pressure, okay? What is the water system here? What do they try for the pressure? Most municipal water supply. What's the water pressure, by the way? How many pounds per square inch? Right? Because it's got a pump from water towers to well all over town. They try for about 50 psi, right? In order to pump that water to everybody's house. Yes? So, anyway, interesting. 120 over 80, 24 over 10. Okay? Again, because the difference in the length of the tubes, much less friction here, not very much pressure. And this side of the heart, much longer tubes, much higher pressure, right? 120 over 80. Okay? All right, figure 17.9, figure 17.9, okay? That is blood flow through the heart. Write that down, because I'm going to ask you questions about that usually. And I need you to sit down, it's a lovely diagram, and read that yourself. I'm not going to go talk through that for 10 minutes. Okay, that's your responsibility, right? I am going to ask you, what does the blood flow through the heart? I'm going to say, blood flows from the left atrium into the, and you're going to tell me. And I may ask you, through such and such a valve. Are you done, Miss?
Almost.
Almost? Okay. So, okay, let's talk about blood supply to the heart. Yes? Because we talked about pulmonary circulation, we talked about systemic circulation, but I left one out. There's a third circulation. And the third circulation is this. The heart has to pump 24 hours. The heart's got to have a lot of blood. The heart has its own circulation called the coronary circulation, right? Coronary, C-O-R-O-N-A-R-Y. The coronary circulation, okay? Now, I am not such a good artist, so that is in figure 17.11. But basically this, you're going to have your left anterior, and the left anterior is going to have a branch called circumflex. Circumflex meaning it goes around the heart in a circle, right? And you're going to have your right anterior, and it's going to come down, and a branch of it is going to go to the back of the heart, the posterior descending, I believe it's called. You don't have to know the names of those, but just realize, okay? You got your left and your right, and the circumflex, and most people are going to get clogs in the left and the right. And oh, by the way, where do they get plaques at? Right? When a blood vessel bifurcates, yes, right? It goes over here and over here. Guess where you're likely to get plaques at? Right here. Right? Yes? But anyway, last year I had a cardiac calcium scan. My father was my size guy, just not so tall. And he was a smoker in World War II. My father was one of the heroes of World War II. And he had a heart attack when he was 50 years old. And by that time, he'd been smoking for 35 years, right? And I was worried, I'm going to have a heart attack someday, right? My dad did, yes. But here's the thing. A skinny man is about 8 times less likely to have a heart attack, unless he's a smoker. A skinny man that's a smoker, almost as much as anybody else, right? So there's a cardiac calcium scan, and what the cardiac calcium scan is, it's a CT scan. CT scan is a fancy X-ray, and I didn't even have to take my shirt off. I laid down and pulled my shirt up, right? You lay on this table and they slide you in the little tubes around there, and your head's up there and you look up there. And the test took about a minute to do. And you lay there and they go, take a deep breath and hold your breath. And they x-ray your heart. And they do that 2 times, right? And what they're looking for is calcium in the walls of the blood vessels. That's what they're looking for, okay? And the score, you get a score that tells you how much calcium buildup you have. It's called an Agatston score after Dr. Agatston. You can look him up on the internet. He's a very cool guy, Dr. Agatston, okay? And so what happens is that this calcium means that you had a plaque, and when plaques, they stabilize over time by forming calcium in there, okay? The scan, right, x-rays, you see bones, right? Well, this is, the old plaques are calcium. Now, the soft plaques it does not show, okay? The soft plaques, it does not show, but the hard plaques, the old ones, it does show, okay? Now, what happens if you have a heart attack is that generally a piece of the soft plaque breaks off and occludes a blood vessel, ischemia. We talked about that, right? But it is very valid. They have this scale, the Agatston scale, and it goes from 0 to 100 is good. Above 100, you have some blockage. 400, oh no, that's not good. That's not good. You better change your ways. You get over 400, I mean, certain people get 1200, 1600. It's scary, right? When their arteries are riddled, right? And again, it's the coronary arteries they're checking, yes? And they give you a score. So I was always worried, I'm going to have a heart attack, right? Well, they do it at BSA. You got to get your doctor to order the test. And if you just go in there paying cash, they'll charge you $100. If you got insurance, no, they're going to charge the insurance company hundreds and probably 1,000. But if you just go in there, I get in there $100 bill, and okay, come with me, right? And I had that test done because I wanted to know, am I clogged up, right? And again, it doesn't show the soft plaques, but studies have shown it is the most accurate for predicting whether you're going to have a heart attack, right? Yes. Now, every once in a while I smoke my pipe that I bought in Istanbul, maybe once a month, but I haven't really ever smoked full time. I've always exercised for the last 35 years. I'm a little overweight, but not much. But anyway, right? Yes. Guess what my score was? 0.5, 0.5 in the circumflex, the one that goes around the top of the heart, right? So perfect is 0, right? Yes. I tried to get several of my friends to go have this test because I got a 0.5 score in the next 10 years, I have a 2% chance of having a heart attack in the next 10 years. 2%, right? But if you get a 200 or a 300, my brother-in-law, who's 18 months older than me, has already had a heart attack and already had open heart surgery, right? But anyway, it's a very good test. It's a very good test. It's not used a bunch because most of the medical doctors didn't grow up with it. It came out in the late 80s and the early 90s. There's a movie called The Widowmaker you should watch. It's very interesting. Because all these people, if they would just have this test, cost $100, they would know, oh, I'm clogged up and I better start exercising and quit smoking and watch what I eat and do all that. And oh, by the way, if you do all those things, you can make your score go backwards, right? But the main thing is if you can hold your score. If your score goes higher and 2 years later it's higher and 2 years later it's higher, way bad, okay? But anyway, yeah, in the circumflex, the one around the top, that's where I had a tiny bit of scarring, right? Now, one of my good friends just had the heart cath. Yes, he's maybe a little older than me, right? Yes, and what do? They cut the hole, they shove the thing up here, they go all the way through, and they check those coronaries, right? Yes. And oh, by the way, you can get an infection, you can bleed, you can die on the table, right? Yes. The other test, you lay there and hold your breath for 10 seconds twice. That's the whole test. I just pulled my shirt up. The lady didn't make me take it off, right? And such, and it's very predictive, and it's not invasive. You get a little bit of x-ray, right? The x-ray is so tiny, yes. Let me ask you, if I gave you a free ticket to New York, would you get on the plane and fly to New York and back? Because when you fly to New York and back, you get more x-ray than I got from that test. Oh, by the way, do flight attendants and pilots have a lot more cancer because they're flying through the air and the high radiation? No, studies don't show that, right? Oh, by the way, you go to Rio de Janeiro and you hang out on the beach, there's more background radiation there than there is here in the States, right? So it's very minor. But anyway, okay. The reason I went into that is, think about that. It's very important to have that test. And a lot of the guys, especially the older ones, they don't use that test. Oh, we better have a heart cath. I had a patient that died on the table, right? And it was a lady, her husband, he died on the table, just doing, oh, we think you ought to have a heart cath. He died on the table. Anyway, right? Okay. Those coronary arteries wrap around the back of the heart, and they come into the coronary sinus. And remember, the coronary sinus is long and flat, and blood pools there before it goes back into the, the one on the back of the heart, they can't do a heart cath back there and open that back up. So that's the one they call the widowmaker. But anyway, because there's not much they can do about it. The ones on the front of the heart, they can't go in there and open them up and put a stent. But anyway, yeah. Okay. Angina or angina, however you want to say it. Let's talk about that. What is that? Okay. Angina, angina, or angina, okay? Angina pectoris, Pectoris, right? This is your pectoral region, that means your chest, by the way, okay? Whenever you have a decrease in whenever you have a decrease in blood flow, and your heart's not getting enough blood, it will cause chest pain, and that is called angina pectoris, or angina, right? A fleeting, meaning coming and going, deficiency in blood delivery to the myocardium. What causes that? Okay, clogged arteries. Number 2, stress, spasms. Okay. Number 3, increased demands on the heart. If I'm 80 years old and then I jump up and the house is on fire and I go running out, right? Increased demand on the heart. Yes? Now, those coronaries, they dilate when you need more blood and they constrict when you need less blood. Okay? But under tremendous stress, they can constrict down. There was one time, right? True story. It was winter. This cat decided, this is the most amazing place in the world I want to live. It was a stray cat in my garage. You know, you open the car, you drive the motorcycle or the car in there, right? The cat kept running in there, and I chased the cat out over and over again, you know? So that upset me. I didn't like that. But then the cat made a fatal mistake. The cat decided to start crapping in my garage. Oh, my word. You step out of the truck and you put your foot down, and, right? Right? Ted Nugent, cat scratch fever. No, cat crap fever. But anyway, just kidding. You guys don't know old-timey rock and roll. Ted Nugent. Sorry. So, I got out of the truck one time and man, big old pile. And it just, I was so mad at that cat and I couldn't do anything to get it away. And so I thought I was going to have a heart attack. My coronaries went like that, and I'm like having chest pain, and I'm like, oh, I'm so mad at this cat. What am I going to do? So I solved the problem. Do you want to know how I solved the problem? And no, I didn't kill the cat. I pulled in the garage. I shut the garage door, and there's the cat in my garage, right? No? I didn't kill the cat. That's a good second yes. So what I did was, you know what wasp spray is? It's got the big long tube on it, right? So I got out of the truck. There's the cat hiding in my garage. So I get the wasp spray and I I soak that cat with a wasp spray, and it starts yelping, and it runs over here. And I chased it over there, and I went, shh. I did that 4 or 5 times. That cat ran all over that garage, could not get away from me. It was hiding behind boards and lumber and this and that, right? And that cat was soaked, and I know it was burning. And then I opened the garage door, and that cat ran out, and that cat never came back, ever. Right? And I felt bad about doing that because I love animals. But sorry, you cracked my garage, your history. It was either that or kill the cat. That's what I was going to do. It's just one of 2 things, right? So, but anyway, but coronaries, they get big. Sometimes people, when they're under stress, they start having chest pain, right? It's very common, okay? Now, the cells of the myocardium are weakened. They're not killed, but they are weakened by bouts of not enough blood, and it's temporary. And what is the treatment for that, by the way? What is the treatment for angina, usually? Angina. Right? Nitroglycerin, right? Tiny little pills in the little brown bottle, and you put them underneath your tongue, and they dissolve quickly, right? And then make your coronaries do this. Get bigger. Okay? They open up your coronaries. It's a big deal. It's the standard treatment. Okay? Nitroglycerin. Okay? There are other long terms, but this is for emergency when it comes on and you have to take nitro. Right? Prolonged coronary blockage can lead to a heart attack, myocardial infarction. The cells die in an acute myocardial infarction. Okay? But again, angina is just not enough blood. It's usually temporary. You take the nitro and the blood vessels get bigger and it goes away. But let's talk about 2 types of stable and unstable. They call it stable, stable and unstable, right? Stable and unstable angina. Okay? Stable angina means this, that as long as I take it easy and I watch TV and I just walk around the house a little bit, everything's fine. But if I start exercising, my chest starts hurting. And then I sit down and it quits. That's called stable angina because I know what brought it on. I exercised, I put more demand on the heart, and I started getting chest pains. Unstable. As opposed to, and this means that's way better to have stable than unstable. Unstable angina means I can be sitting there watching TV and watching a movie, and all of a sudden, chest pains, and they come and go. And it's not because I got up and I exercised, okay? Now, the big deal is this. Unstable angina without exercise or anything is very scary. That's a red flag. That means you're probably going to have a heart attack. That means you got something major going on, and your doctor needs to know about that, okay? Stable angina, okay, we know you got some clogged arteries. Take your nitro. Don't exercise too hard, and you're probably going to be good. But unstable, you're just sitting there, and out of the blue it comes on, and you're having the chest pain. That's way bad. Unstable, okay? That means there's a high probability you're going to have a heart attack. That's a red flag, which means, oh crap, you better check into that and figure out what the problem is, okay? So, that's the difference, okay? Now, let's talk a little bit about, we said, remember too, in a previous chapter, if you have ischemic heart disease, if you don't get enough blood to those cardiac cells can die, and then you get fibrosis. You get scar tissue. And that scar tissue does not do the function of the cardiac cells that contracted, right? So when you have a heart attack, it weakens your heart. If you have multiple heart attacks, it weakens your heart more, okay? Because those contractile cells, those coronary muscle cells, they're not there. It's just scar tissue, and scar tissue does not contract. It cannot do the job. It's fibrotic. It's fibrosis. It's a scar, right? And so that is why having a heart attack scars your heart, and having multiple heart attack. If this is your heart, maybe you have a heart attack, and maybe you have an area where the blood was cut off. That's going to be scar tissue. Oh, by the way, a year or 2 or 3 years later, you have another one here. Oh, by the way, maybe a year or 2 later, you have one here. Right? Yes? So these areas will be fibrotic tissue. They'll be scar tissue. Right? They're not going to be that contractile tissue. Okay? And the left ventricle. The left ventricle is thicker, it's more muscular because it's got to pump the blood further, and that's where it's the most dangerous to have a heart attack, that left ventricle. Okay? Okay. Now, let's talk a little bit about the microscopic anatomy of the heart. Okay? Okay? Pardon me, just a second, let me see where I'm at. Microscopic anatomy of the heart, yes? Remember the heart cells shaped like this? And the heart cells, the hallmark of the heart cells is on the end they have intercalated discs, D-I-S-C, an intercalated disc, right? Yes? And what is that? Okay? The heart has to work together. All the top has to squeeze, the bottom has to squeeze. You want the whole bottom of the heart to squeeze at one point, like that. And that intercalated disc helps the electrical signal go from cell to cell to cell to cell. Okay? Okay. Okay? The hallmark of cardiac tissue is intercalated discs. Okay? Now, you also have the desmosomes. Desmosomes are, right? You have that in other parts too. It's where two cells are hooked together almost like Velcro. Desmosomes. Go back, you can look, I think it's chapter 1. It's in, right? Yes? Because when I'm running full speed, I'm sprinting, boom, 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 the heart's really pounding, right? It would not be good if those heart cells tore apart, right? They need to be anchored together very strongly, okay? Right? Those are called desmosomes, right? And they're just like Velcro, okay? Now, 2. You also have gap junctions, okay? A gap junction looks like a flower, like that. Yes, and it's a tube, and if you look at it from the side, it is kind of a tube. Like that. Yes? Now, these gap junctions, so the heart can all contract smoothly. You have little, kind of like little bitty tubes, right? I believe they're called connexions in between the two. And basically, electrolytes, sodium, potassium, calcium can flow through those channels. So that way, you have close communication between those cells, so they can all contract at the same time, so you pump a lot of blood out. Okay? And again, those are called gap junctions, G-A-P, J-U-N-C-T-I-O-N-S, gap junctions. We talked about that in chapter 1 or 2. Okay, the junctions, ion pass from cell to cell, and they electrical couple the cardiac cells. They're hooked together, okay? And that way the myocardium behaves as a unit, as a single unit, right? Okay? Now, if we take a muscle cell, if we take a smooth muscle cell, about maybe 2 to 3%, maybe 2% or so of the weight of that cell is mitochondria. And we talked about the mitochondria is the powerhouse of the cell, right? And it's the powerhouse of the cell, and it's where we make ATP, right? However, in a cardiac cell, 25 to 35% of that cell is mitochondria. Of the volume or weight, I should say, of that cell is mitochondria, right? Why is that? Because when I lay in bed and I'm sacked out, do I need to have a lot of muscular activity and I rest those muscles? No. But guess what? The heart beats 24/7. It never gets a break. Almost never gets a break. Okay? And so because of that, it needs a lot of ATP. So you need a lot of mitochondria. Right? And that's why exercise keeps those mitochondria toned up. Okay? Now, let's talk about heart cells, these cardiac tissue, these heart cells, okay? Right? These heart cells have a very unique feature called autorhythmic, right? Auto means self, okay? Now, what that means is this. If we talk about skeletal muscle, I think I'm going to bend my arm. I send a signal from here to my arm, and the nerve, the action potential, and I'll bend my arm, right? These cardiac cells can contract on their own, right? They can contract on their own. Autorhythmic, they can set their own rhythm, okay, to where they will contract, right? Now, when I was in high school in the olden days, right, my Bio 2 teacher, Mr. Rourke, right, we cut a live frog open and we cut his heart out. And that heart went boom, 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 boom for about an hour outside the frog. Because that is autorhythmic. It sets its own. In time, it'll stop. But for a long period of time afterwards, even though it was taken away, the nervous system was taken away, it was autorhythmic. And we will talk about how, we talked about autonomics, and we talked about how we have our sympathetic system that's excitatory, and we have our parasympathetic system that calms down. And the heart is dominated by the vagus. Number 10, we talked about cranial nerve number 10, the vagus. The only nerve that goes below the neck is vagus, baby, right? Vagus. And it's parasympathetic, and it calms things down, and it makes us digest our food. And guess what? It dominates the nerve supply to the heart, and it makes our heart beat about 75 beats per minute. But remember, these cells are autorhythmic. If you cut the vagus nerve and you no longer have that parasympathetic influence, guess what? Because the cells are autorhythmic, the heart will still beat on its own, but it'll go boom, 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 about 100 times a minute. Because you took away that parasympathetic influence. We also said, oh, by the way, we will learn the blood vessels are dominated by the sympathetics, but the heart is dominated by vagus, baby. Number 10, cranial nerve, the parasympathetic. Okay? Okay. About 1% of the cardiac cells are autorhythmic, 99% are not, but that 1% is autorhythmic, which means it'll contract on its own. It'll depolarize spontaneously, right? Okay, real quickly. We already said that. Ischemia. ISCHEMIA, right? Lack of blood, ischemic heart disease, coronary heart disease, whatever you want to say. Ischemia means blood deprived, right? And if it continues long enough, you're going to have a heart attack. And when that happens, certain cells in your heart, you're getting a buildup of acid, hydrogen molecules, the protons, right? And such, okay? The hydrogen goes up, and the calcium levels go up, okay? And when that happens, the mitochondria are damaged. They don't produce ATP, and you can die. Right? When the calcium gets too high, those gap junctions that allow the interconnection between the cells, they close, okay? And you go into fibrillation, either atrial or ventricular fibrillation, and we'll talk about that in a little bit. Okay. Now, on our diagram, let's talk about some very special cells. Let's talk about the pacemaker for the heart, okay? The pacemaker for the heart. What color should I make that? Okay. Okay. It's a sinoatrial. This one's the AV, the atrio ventricular. This is the SA node. This is the AV node. Okay. And this is the what's called the bundle, B-U-N-D-L-E, the bundle of HIS, H-I-S. But the other name for it escapes me. 1 second. Yeah, the AV bundle. AV bundle. Okay? Let me explain what all that means. The start of your heartbeat is right here in the SA node. Remember we said it's autorhythmic. It's influenced by the vagus. Normal heart rate about 75 beats per minute. The signal will go from the SA node to the AV node. AV for atrioventricular, okay? Then to the AV bundle, and the AV bundle is in the septum of the heart. And another name for the AV bundle is the bundle of HIS, H-I-S. I assume that's an eponym, somebody's name, okay? From there, you will have a left and a right branch, sometimes called bundle branch. And then here, you will have the tail end of the chain here. And those are called, our book says, okay, the famous name is Purkinje, P-U-R-K-I-N-J-E, Purkinje fibers. And the book says subendocardial, what is it, subendocardial, conducting network, N-E-T-W-O-R-K. I never heard of that, but anyway, I guess they're trying, for many terms, they're trying to change the name, okay? Everybody that I went to school with, this is the Purkinje fibers, right? So what happens is, the excitement starts here, SA node, then it goes to the AV node, then it goes to the bundle of HIS, or the AV bundle, left and right bundle branch, and then finally coming around here, it's the Purkinje fibers, or the subendocardial conducting network, okay? Okay. Let me see, there's a diagram. Okay, you can look at that diagram, figure 17.15, and you will see that. Okay? Okay. Now, the SA node. The SA node, okay? The SA node is in the right atrium. Notice it's in the right atrium. Okay? And it's going to beat about 75 beats per minute. Okay? And again, if the SA node is destroyed, then it'll go up to 100. Okay? Okay? The AV bundle right here, AV for atrioventricular. That is how the top part of the heart and the bottom part of the heart communicate, the AV bundle, okay? This controls from here down, all right? Yes. When the heart beats, the contraction starts down here at the apex and then goes up, okay? Sometimes people's SA node, they have problems with it. It does not function properly, and so the AV node will take over. If the AV node takes over, then you'll get about 50 beats per minute, okay? 75 for the SA node, 50 if the AV node takes over, okay? Now, if both of these are knocked out, guess what? The AV bundle, yes, you'll get 40 to 60 beats per minute, right? What are you doing if your heart's beating 40 beats a minute? If you're a marathon runner that's world class, you're doing anything you want to. But for most mere mortals, if your heart's beating 40 beats a minute, what are you doing? You're laying on the couch because you don't feel like getting up because your heart is barely beating, right? Okay. Okay. Now, this intrinsic system, SA, AV, SA, atrioventricular, the AV bundle, Purkinje fibers. If you have problems with that conducting system, then your heart may beat irregularly, okay? Arrhythmias, right? Arrhythmias. Arrhythmias, arrhythmias, right? A means not or without rhythm. Your heart won't have the proper rhythm, okay? And when that is bad, then you get what is called fibrillation. Fibrilation, right? And you have atrial, atrial, and you have ventricular, right? Atrial fibrillation is very common among older people. The top part of the heart is supposed to go shh, 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 right? But when those cells are not working together, then they won't all squeeze down at the same time, and it has a hard time squeezing all that blood out. And you will get some backflow. In the backflow, anytime you get backflow floating around in parts of the heart, you can get an embolism. An embolism can float around and you get a heart attack or you get pulmonary, it's way bad. Stroke more commonly, okay? So that's what happens. And when you have AFib, instead of this, you get unconcentrated, uncoordinated movement, okay? Very common. And so when that happens, you don't feel good, your heart feels weird in your chest, you may be tired, it's hard to get up and walk and move around and do things, okay? It's very common. AFib, right? Now, people with AFib have more strokes. Is it because the AFib? We don't know exactly. I watch a cardiologist guy on the internet from England and such. He's very interesting. But is it the chicken or the egg? Is it the AFib cause that, or people that already have clogged arteries have a tendency to get AFib? But anyway, VFib, right? Guess what happens? Remember, the ventricles are the main pumps. Guess what happens when you go into VFib? AFib, you feel bad, you may get hot and sweaty, and your heart's not beating right, you may feel it flutter, right? When you have VFib, guess what happens? Very quickly you fall on the ground and you die unless somebody does CPR on you, okay? That's what happens. You get VFib, boom, very quickly you're going to fall on the ground, okay? And hope somebody knows CPR till the ambulance gets there, okay? That's what happens. AFib, you can take this, not squeezing enough blood down in here, but you cannot take this heart writhing and not squeezing properly and sending the blood where it's supposed to go. You cannot take that. You will fall on the ground. Okay? Okay? Uncoordinated atrial or ventricular contractions, rapid contractions dominate the SA node. The heart becomes a useless pump. Da 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 da. Right? And they have defibrillators now. Yes? You know, the defibrillators is where they take the metal paddles and they rub them, they shock you, and that will many times establish your heart rhythm again. Yes. Well, they have implantable ones now, so they don't have to do that. But what happens is, if your heart goes into defib, it'll shock you. And they say it feels like a mule getting kicked in the chest. Kicked you in the chest is what it feels like. But it'll start your heart going again. Okay, it's very common. There was one of those, what do they call the system in the Cadillacs where you push the button and you talk to them and you can call an ambulance or whatever? OnStar, okay, yeah. There was a commercial for OnStar and the guy, he pulled over and he hit the button. He said, I'm having a heart attack. I got a defibrillator. I need an ambulance right here. Ah! You know, oh, the thing just went off. Please get the ambulance here pretty quick. Ah. You know, and he did it 2 or 3 times. It went off. He felt like he was getting kicked in the chest, but he kept him alive till the ambulance got there. But anyway, implantable cardio defibrillators, ICD. Okay? Okay. Now, there are certain people that have difficulty sometimes. The SA node doesn't work properly, and there will be other spots around that cause the heartbeat, right? And that is called ectopic foci. Oh, by the way, tell me what this is. What is that? Okay, you can say it.
Oh, me?
Yeah.
Oh, egg?
Huh?
An egg?
Yeah, very close. Right? Right? That's a tubal pregnancy, right?
Mm-hmm.
Only we don't call it a tubal pregnancy. We say it's a what pregnancy? Ectopic. Ectopic pregnancy, right? It ain't supposed to be there. It's supposed to be over here so it can grow into a baby. If it attaches here and grows over here, the baby's not going to live. You're going to have a spontaneous abortion because it can't grow in the tube. Tubal pregnancy, right? They're very common. And usually, it'll be expelled and then you'll be able to have another baby in a short period of time. But anyway, tubal pregnancy is called an ectopic pregnancy. When the parts of your heart cause this extra beat, that's called ectopic foci. An area where it's not supposed to start, it starts. Okay? And so what happens with that is your heart will beat, and then one of these ectopic foci, oh, by the way, what sets those off? Right? Drugs, way too much caffeine, double espresso latte, blah, 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 right? Stress, okay? And what will happen is your heart will beat, and then it'll beat again very quickly. And when it beats again very quickly, it didn't have enough time for the proper amount of blood to flow in. So the second heartbeat will have just a little bit of blood with it. And then there will be a period of time and the atria will overfill. And then you'll get a heartbeat, kaboom! You feel a big thud, right? And you get a PVC, premature ventricular contraction, it's called, right? PVCs. Normally, we're going to have the P, the QRS wave, and the T wave, right? But when you have PVCs, it looks like this, right? The P wave and that are obscured, right? Now, I took EKG 40 years ago, but anyway, I had a paramedics in here. They're like, "Hey, Dr. Well, that's what it is." And you start having heart trouble, you'll start throwing PVCs. They'll look at that and they go, "Oh, he's having PVCs," right? Where the heart beat, and then it beat again quickly, and then the next beat, great big volume of blood, and kaboom! And it'll look like this on the EKG as opposed to this, right? Right? The atrial depolarization, the ventricular depolarization, the atrial repolarization. That's your PQRS and the T wave, okay? Right? You can look more into detail on that in the book. But anyway, PVCs, right? Some people have PVCs. I had a student, she had them all the time when she got under stress or heart. She would feel that thump, thump, thump in her heart and such, okay? I'll write it down. Premature ventricular contraction. They just say PVCs. Oh, he's throwing PVCs. And they'll give you some medicine for that. Okay? Okay. Now, a little bit about the EKG very quickly. I took EKG 40 years ago, and I remember the instructor said, okay, if you've taken this class before, please stand up. And there were a bunch of guys in there that I didn't know from my class. There were like, 240 guys that started in my class. And there were all these guys, where did these guys come from? They were upperclassmen, And he said, if you're taking this class for the second time, please stand up. Some of these guys, a bunch of them stood up. And he said, if you're taking this class for the third time, remain standing. Some of the guys sat down and a bunch of them were still standing. If you're taking this class for the fourth time, remain standing. There was like 10 guys standing there taking that class for the fourth time because it was hard. It scared the stuffings out of me. And you know what I did? I stressed out and I studied my fanny off and I made an A in that class. But anyway, yeah. What I want to say a little bit about this is the cardiologists are amazing. They can look at that strip and they know what's going on with your heart. Okay? True story. My father, when he was 72, they did an EKG on him and he had an inverted T wave. PQRST. Had an inverted T wave. And so the person giving him the EKG said, oh, Mr. Weld, when did you have a heart attack? And he said, my father was like 72. Oh, that was when I was 50. They said, no, your recent heart attack. When did you have your recent heart attack? And he said, oh, I didn't have a recent heart attack. But he had an inverted T wave, right? Showing damage to the heart, right? And my father, he thought about it, and he said, about 3 months ago, I got up on Saturday morning and I felt miserable, and I walked down the hallway and laid on the couch, and I laid on the couch for 3 days. I felt terrible. Yeah, he was having a heart attack. He didn't even go to the hospital. But anyway, my father was a manly man. He was a little guy like me, but he was a tough guy. He didn't say much, and he never complained. I wish I was more like him. But anyway, the technologist knew that he had a recent heart attack. And sure enough, right? But anyway, the guys are amazing. The cardiologists, they can look at that strip, they can read it, and they can look at what's going on. This shows the electrical activity of your heart, and they know, okay, maybe they got problems here at the SA node, right? Or maybe there's a different pattern. I used to know it because I studied it 40 years ago, but there's a here, and if it's with the bundle of discs there, it's called an AB block. And you can have a right bundle branch block or a left bundle branch block. Just by looking at that strip, they can tell you it's the side of your heart or the side. It's amazing what those guys know. It really is, right? But anyway, so, okay, interesting. Okay, let's talk about the nerve supply to the heart real quickly. Well, first off, let's take a break for a minute because I know you're tired and I'm tired. Okay, sorry, this is there's 2 less chapters, but some of them are very long, right? I went home last night and cut the grass in the backyard with a push lawnmower. I was so tired, and now I need to do the front tonight, and I'm so tired. I don't know if I'm gonna do it or not. But
She's not answering. I can't answer her.
Is that after the 6 minutes?
Yeah.
I just texted my brother. I just told Grace. Break. And they're like, That's crazy. One umbrella, really? Yeah, I know.
oh, man.
Getting ourselves working.
Okay. Okay. Let's talk about the nerve supply to the heart. We said the heart's dominated by parasympathetic, right? And the parasympathetic comes from vagus, right? Remember, one of the cranial nerves, number 10, the big one, the only one that goes below the neck is vagus, right? So vagus comes from the medulla, right? The tail end of the brain, the medulla oblongata. One on each side, comes down, controls all the guts, right? All that stuff, down to about the first third of the large intestine. Okay, that's vagus. It's a very important cranial nerve. And that's parasympathetic. And parasympathetic is rest, relax, digest, right? Okay? Now, however, the sympathetics come down through the, from the medulla through the, remember the sympathetic chain, right? Remember, sympathetics, short preganglionic, long postganglionic, right? Remember, the parasympathetics are long and short, the opposite, right? Long pre, short postganglionic. But anyway, okay? So, again, there's a lovely diagram in your book, way better than this, but you get that. The main thing, what is it? Sympathetics, T1 to T4. Parasympathetic, vagus, baby, number 10. Okay? Number 10, vagus, parasympathetic, calm everything down. Sympathetics, speed that heart up. Okay? Get it going. Right? Okay. Let's see, do I have a, yes, figure 17.16, the autonomics, right? The autonomics. Okay, now let's talk a little bit about, okay, I'm sorry. One thing I wanted to mention. In the medulla, a lot of the sympathetics are controlled there, right? The autonomic nervous system, right? You have a cardio-acceleratory and a cardio-inhibitory, right? If you drive a car and you put your foot on the accelerator and you push, where do you go? You put your foot on the accelerator, what does the car do? It accelerates, thank you. So the cardio-acceleratory makes the heart speed up, right? If I'm going to run a race, then my heart needs to speed up. Oh, by the way, the cardio-inhibitory makes the heart slow down, right? Makes sense, right? Okay. Okay. Now, let's talk about the heart sounds, okay? The heart sounds, auscultation of the heart. Remember, we said auscultation back to chapter 1 is listening to the heart sounds, okay? Right? Now, the first heart sound, when you listen to the heart, it sounds like this. Lub, dub. That's what the heart sounds like, right? And the first sound comes from these AV valves closing. That's where the lub comes from. And the D comes from the pulmonary and aortic valve closing, right? The semilunar valves, right? And that is the difference, yes? Okay. The first sound, the AV valves closing, is the beginning of ventricular systole. Systole means squeezing, when the heart squeezes, right? That's how I always remember, systole, squeezing, right? Okay. The first sound is louder and longer than the second sound, and the second sound is shorter and sharper. Okay. And the second sound is when these close at diastole, which is the opposite of systole, when the heart relaxes, diastole. Okay? Yes? Okay. Heart murmurs. What are heart murmurs? Heart murmurs are when your heart makes an abnormal sound, and it's usually caused by the valves, a valvular problem. And oh, by the way, little children, they don't have much chest wall. It's very thin in a little child. And so it's very common to hear heart murmurs and not really that big a deal most of the time, okay? That's another thing. Before your baby leaves the hospital, they're just to the heart to see if it has any heart murmurs or anything like that, okay? When you hear the normal sounds, that's normal blood flow through, but we have two common problems. Okay? Incompetent valves, incompetent or insufficient valves, and that means the valves don't close properly, or they don't close tightly. Okay? Now, the other is stenotic, S-T-E-N-O-T-I-C. We'll talk about that in a moment. But anyway, these valves, remember we said the tricuspid 3, the bicuspid 2, the semilunars 2, right? If they don't close all the way, then as your heart is beating, you'll hear swishing sound, okay? Swishing sound, okay? Conversely, the opposite of that is stenosis or stenotic, okay? Stenosis means a closing down, okay? In your spine, right? Here's your spinal cord right here. And if you get a buildup here and here, that's spinal stenosis. The spinal cord is getting closed down on, right? In the same way, if the valve doesn't open all the way and then close, if it doesn't open all the way, you'll get a clicking sound. C-L-I-C-K-I-N-G. It is said to be stenotic, okay? That's what that means. It's closing down. It's not opening up like it should and closing like it should. It's too tight, okay? It's too tight, okay? Stenotic, the valve fails to open completely, and the narrow opening restricts the blood flow, okay? And again, you get a click, and it can be very high-pitched, okay? Now, in my work, I do not listen to hearts very often, every once in a while, but not very often. I'm not an expert. But I assure you, like my friend Dr. Thetford, when he was here, man, he listened to a million hearts, and he knows, right? In fact, he had this stethoscope that was like $2,500, and he said, hey, Dr. Vermerdal, come over here. Dr. Vermerdal had one too, and he could push a button, and the sound from the patient's heart would go to Dr. Vermerdal's, and Dr. Vermerdal's like, you hear that? Oh yeah, wow, that's cool. Anyway, yeah, amazing technology. But anyway, stenosis or insufficiency or incompetent means they don't close, right? Sometimes people have heart valve problems and they have to have them replaced. I have a patient like that. You had to have that heart valve replaced, right? Blood flow through the heart. Blood flow through the heart is all pressure. It goes from high pressure to lower pressure. When the blood flows in here into the atria squeeze and push the blood down in here. Then the ventricles squeeze and push the blood out of the heart. Okay? It's about pressure. So the blood is going to go from a high pressure to a lower pressure area. When these squeeze, there's low pressure here. When this squeezes, there's lower pressure in the vessels and the blood goes out the vessels. Okay? It's all about blood flow. Right? It's all about pressure from high to low. Okay. We already talked about that, how the pulmonary side of the heart, the left side of the heart, it's like 24/10 if you check the pressure. Here it's 120/80. Right? It's 120/80 because it's got to pump that blood all the way to my big toe. Here it's just got to pump the blood. There's less resistance just to my lungs. Right? I talked about that, didn't I? If I did, yes. Okay. Let's talk real quickly about cardiac output. Okay, cardiac output. I'm just going to write CO, cardiac output. Okay, cardiac output is the amount of blood pumped out by each ventricle in 1 minute. Okay, cardiac output is equal to the heart rate times the stroke volume. Okay, the heart rate is how many times your heart beats a minute, right? Normally your heart's going to beat about 75 beats per minute, yes? And the stroke volume is how much is squeezed out of that ventricle, and normally that's about 70 mils, okay, per minute. Okay, 75 times 70 is equal to 5250, right? Yes? 5250 is 5.25 liters, right? How much blood did we say normally a person has? 4 to 6 liters, right? 4 to 6. And so basically, what does that tell you? That means a drop of blood goes through your heart, circulates to your body, and back to your heart about 1 time a minute. An average person takes about 1 minute for that blood to make the loop and come back to the heart. Okay? That's if you're resting. Okay? About 1 time each minute. Yes? Now, think about this. Cardiac output, right? Because I'll probably ask you a question about this. If the heart rate goes up, what's going to happen to the cardiac output? If the heart rate goes up, what's going to happen to the cardiac output? Greater or less?
It goes up.
Okay? If the heart rate goes up and your heart's beating faster, more blood's going to be pumped out, so it's going to go up. If the heart rate goes down, heart squeezing less times, beating less times, it's going to go down. Now, what about the stroke volume? Let me explain the stroke volume. Stroke volume, we have about an average of about 70 mils of blood a minute. But when we're running, that heart's going to stretch some and it's going to squeeze even more blood. So if the stroke volume goes up, what's going to happen to the cardiac output?
Go up.
This is going to go up, right? Yes? If the stroke volume goes up, the cardiac output goes up. If the heart rate goes up, the cardiac output goes up. Conversely, if the heart rate goes down, you're getting less blood pumped out, right? So cardiac output will go down. Stroke volume. If the stroke volume goes down, cardiac output will go down, right? Doesn't that make sense? If you think about it for just a minute, doesn't it make sense? Your heart can either push out more blood or it can beat faster, and both of those you're going to get more blood out of your heart. Or it can slow down and the amount that it's squeezing out can get less, and that's going to make cardiac output go down, right? If I'm laying on the couch, I may have so much cardiac output, but if I get up and I'm running a 5K, I'm going to have a lot more cardiac output, right? My heart's going to be beating faster, right? My stroke volume is going to go up. That old ventricle is going to get stretched. It's going to be squeezing. Yeah, right? So if you think about it, it's really not complicated. If this goes up, cardiac output goes up. If this goes down, cardiac output goes down. If this goes up, cardiac output goes up. If this goes down, cardiac output goes down. Either or. If both go up, this really goes up. If both go down, this really goes down. Okay, does that make sense? Okay, now let's talk about cardiac reserve. Cardiac reserve, okay? Cardiac reserve, right? What does that mean? Okay, that means this. Okay, think about this. If I'm a couch potato and I never exercise, right? Yes? The hardest I work is walk to the refrigerator and back, yes? But then all of a sudden, if the alarm goes off and my house is on fire, yes? Or my apartment's on fire, I'm gonna get up and I'm gonna run down that hallway and get the heck out of the house, right? So I have a reserve there. Normally I'm sitting there, my heart's beating so much. But even if I'm a couch potato, I have some reserve there so I can jump up and run down the hall, okay? So, cardiac reserve in an unfit person is probably about 5 times. Instead of that drop of blood going through my heart 1 time in a minute, it'll go through in 5 times, 4 to 5 times, okay? If I just have to, if I'm a couch potato, I can get up and I can just go, right? So I have reserve there. I can run if I have to, not very far, not very long, but I can if I have to because I have cardiac reserve. But think about this. Think about someone who's on the high school track team, right? And they're a well-conditioned athlete, right? Their cardiac reserve may not be 4 or 4.5 or even 5. Their cardiac output may be, their cardiac reserve, pardon me, may be 7. So that drop of blood can doom, 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 go through their heart 7 times in a minute. Yes? This last weekend I was going up that mountain. I was almost to the top, and I'm telling you, my heart was pounding. I mean, it was just boom, 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 boom. Right? My cardiac output was way up. Yes? But I'm a trained athlete, and so I can do that. It was funny too. There was a young guy there, almost to the top, and he had this mega backpack on. And he's like, I feel dizzy. I think I'm going to faint. So I had to go over there. Okay, sit down, calm down, relax, take a few breaths. You're going too fast, you know. And so I stayed with him about the last 30 minutes to get him to the top of that mountain, and then I went down. But anyway, he's from Kentucky, and there ain't too many mountains in Kentucky, especially 14,000 feet. But anyway, right? Cardiac reserve. An unfit person, maybe 4 or 5 times it'll go up, but a real trained athlete, 7 times. That drop of blood will go all the way through that system 7 times. Okay? The resting amount. Okay? Now, let's talk just a little bit. Okay? Let's talk just a little bit more about how sympathetic stimulation. What's that going to do to the heart rate? Up or down? Sympathetic. Sympathetic. It's going to shoot that heart rate up. Yes? Parasympathetic, heart rate's going to go down. Right? Okay? Okay? Sympathetic. Sympathetics, you're dealing with epinephrine and norepinephrine. Right? And remember we said these 2 hormones are called the catecholamines. Catecholamines. And the parasympathetic, right, we're dealing with acetylcholine. Right? So this is going to slow the heart down, and that's going to speed the heart up. Yes? When you have proper amount of heartbeat to match your activity and this and that, that is called vagal tone. V-A-G-A-L-T-O-N-E. Vagal tone. Right? Yes? Well, what in the heck does that mean? The heart is dominated by which nerve? What cranial nerve dominates the heart? Vagus, baby. Vagus. What's the only nerve that goes down? Cranial nerve that goes down below the neck? Vagus, baby. Vagus is parasympathetic. Vagus calms it down, right? Yes? And so when I have the proper amount of vagal tone, my heart's beating just right for my activity, meaning if I'm sitting on the couch, it's slow. If I get up and I start walking fast, it goes faster. Vagal tone, right? If I'm sitting on the couch and the heart beats way fast, that's bad. If I'm sitting on the couch and the heart beats super slow, not enough to keep me going, that's way bad, right? Okay, so vagal tone, right? Okay. Cardiac output results in corresponding changes to systemic blood pressure. Okay? What does that mean? If your cardiac output goes up, your blood pressure is going to go up, right? If I'm laying on the couch, my blood pressure may be low. Late in the evening, sometimes I'll take my blood pressure and it'll be 100/60, right? But if I'm at the office and I'm going from room to room and I'm dealing with people and I'm talking to people and I'm moving around, my blood pressure may be 130/88, right? But if I'm in the chair at night and I take it and it's 100/60, right? Okay? And so the cardiac output is going to influence my blood pressure, okay? Right? Let's talk a little bit about that real quickly. Okay? In the walls of my blood vessels, I have baroreceptors, B-A-R-O, R-E-C-E-P-T-O-R-S, baroreceptors. Okay? Now, if you recall, the heart is dominated by vagus nerve, parasympathetic, but the blood vessels are dominated by the sympathetics. Okay? And the baroreceptors, right? Yes? Oh, what does that sound like? Anybody have one of those things that hangs on the wall and it goes like that, depending on the pressure? Right? What is that called?
Barometer?
Barometer, right? And these baroreceptors do this and this, depending on the pressure, right? And those baroreceptors send signals, stretch receptors, to the medulla, right? And the medulla is where a lot of the autonomics are, right? Remember the cardioacceleratory and the cardioinhibitory? Yes? And so what happens is that these baroreceptors send signals to the medulla, and they either speed the heart up or slow the heart down depending on what the pressure is. Okay? And we're going to talk a lot more about that maybe tomorrow. Okay? So, I got to grade this test and turn that in. Ms. Ariana, I'm going to grade this test and then I'm going to give it to you to put on Ms. Lexi's desk. Okay? Thank you. Okay? And other than that, see y'all tomorrow, and we'll probably finish up this chapter and do a little bit of the next chapter and do some lab, okay? Yes? So, thank y'all. Have a great evening, and anybody want to volunteer to go home and help me cut the grass? I'd really appreciate it.